Yeah. My hair doesn't get longer, it's just sort of out. So it gets pretty unruly.
I know.
Good evening, ladies and gentlemen. How are you? Okay, that works. All right. And then all right, it's 7 o'clock. Good evening, all. So do try to get your assignments in to me in as timely fashion as possible. And next week, we'll have class on Monday. The final is Wednesday. I'm going to try to put the final on the computer. Can you guys all bring computers to class and do the test on the computer? You all have devices you can use. Parts will the final be? Questions? 50. 50. Normal class time. And then after class, we'll have a shindig at my house. And it's very close. I walk to work every day. It's 112 Marietta. So if you go up Teft Road, so Marino's, that road, you go up Teft Road, it's the first road on your left. And then once you turn left on Marietta, it's the third house on the left. It's 112. The road kind of goes up a hill like this. We're kind of sort of at the top of the hill, kind of. And we're going to supply probably little chicken wings things or hot wings. So you guys bring chips, salsa, fruit salad, whatever your culinary spark lets you bring. If you want to just buy a bag of chips and bring that, that's fine. And if you really end up with the short end of the stick and you can't bring anything, just come. Or bring some water or bring some soda or bring some whatever. Yeah. Yeah. In all honesty, your study guide is your ATI book. I essentially take questions. Well, not straight from this, but mostly from this. Because this is the kind of stuff you'll get on the NCLEX. And since I took over, well, since I wrote this class and took it over, I've changed the way I've taught it immensely. And I've watched a lot of YouTube of nurses to try and get the idea of, well, no, nurses don't need to know about biochemistry. They need to know more about, where to put the bed for the patient and what can they eat or drink with it and that sort of thing. So I've tried to include more of that sort of thing. And that's been a big switch for me. But I think it'll help you guys as you go off into the clinicals and what have you. I still am very convinced that nurses who can think mechanistically can often think on their feet better than those who just memorize stuff. So that's why I am very mechanism driven. And I hope that has helped you to kind of think more mechanistically. It's not easy, but I think it'll make you a better nurse. So Amanda last time talked about diabetes from a patient perspective. I hope you got a lot of, yeah, Abby? Yeah, yeah, unless you really, really, really want another quiz.
That or like if we did another one, we just drop like our lowest.
Yeah, I probably could.
I also, we also extra credit, like let's do extra credit like for play purposes or how about that?
It's just gonna be like 20.
Yeah, so you can do the 3 science seminars. You can do one that I require 2. You can do 1 extra. There's the focus. You can do that. And then apparently the case study 4 is gravy. So yeah, Emily?
How many will the final be 50 points then or 100?
No, it'll be 100.
100 points?
Be 100, yeah. 50 questions, 100 points. And they'll be mainly multiple choice, multiple answer, and true false. Okay. All right, so Amanda gave you what it was like to be a diabetic. I hope you got a feel for kind of seeing it through the patient's eyes. Amanda is good at kind of bringing humor into it, but I think you'd agree diabetes is no laughing matter. It's a serious disease. You have to treat it seriously. So I'm going to just blast through essentially what goes wrong with diabetes and how medications can mitigate it. Then we'll hit the actual medication. These 2 PowerPoints I put on Blackboard. If you want to look them up and follow along, you can. So metabolism consists of reactions that make things and reactions that break things. The reactions that make things are called anabolic reactions. That arm of metabolism is called anabolism. The reactions that break things involve the breakdown of larger molecules like proteins to amino acids, like fats to fatty acids and glycerol, like glycogen to glucose, so on and so forth. So that arm, those are catabolic reactions. How does your body know which one to do? The answer is a certain mix of hormones. Certain hormones for some molecules are anabolic. For others, they're catabolic. The most important anabolic hormone in your body is insulin, by far. Insulin promotes the synthesis of glycogen from glucose. It also promotes the utilization of glucose to make ATP. It promotes the storage of fatty acids as fats. It also promotes the conversion of glucose to fatty acids and their storage as fats. And it promotes the uptake of amino acids by skeletal muscle and their synthesis into protein. That's one reason why workout shakes will often have, with a bunch of amino acids, whey protein, stuff like that. It'll also have some sugar in it. And that sugar is meant to promote insulin production so that the insulin tells your muscles to make protein with the amino acids you're feeding it after you work out. So each of these has various anabolic traits, and this particular table here will show you that, but the one I want you to focus on in this whole thing is insulin, because insulin, as you can see, is the pro-anabolic. Across the board, it's anabolic, and it's largely opposed by glucagon. Everything insulin is, glucagon is not. Everything glucagon is not, everything insulin is not, glucagon is. So glucagon promotes the breakdown of glycogen to glucose. Glucagon promotes the breakdown of fat to fatty acids and glycerol. Glucagon has nothing to do with protein, but glucagon also promotes the breakdown of fatty acids to ketone bodies. Whereas insulin inhibits ketogenesis, glucagon promotes ketogenesis. So glucagon and insulin are in this push-pull fight that essentially makes the homeostasis, glucose homeostasis in your body. So this picture essentially illustrates what I was trying to say in a graphic manner. Namely, insulin will promote glucose uptake. That's why when you take insulin, glucose levels drop, because insulin promotes glucose uptake. It promotes a conversion of glucose into glycogen, particularly in the liver. It promotes the uptake. If there was skeletal muscle here, it promotes the uptake of amino acids and its conversion into skeletal muscle proteins. And it promotes, as you can see, the uptake of glucose, its conversion into glycerol, the uptake of free fatty acids, and the synthesis of fat and storage of fat. Glucagon promotes the release of glucose by liver after glycogen is broken down. Liver is the only organ that releases sugar. All the other organs of your body, when glycogen is degraded, that glycogen, that glucose that results from the breakdown of glycogen stays in the cell because the glucose is phosphorylated. Phosphorylated glucose moieties cannot be exported into the cell. The phosphate has to be lopped off. That enzyme, glucose-6-phosphate phosphatase, is only present in liver. So think of it this way. Liver is the organ that loves to share. It shares its glucose. It's a very Christian organ. It shares. Whereas all the others are selfish brutes. They hoard their glucose for themselves. The most Christian organ you have in your body is your liver. Okay, that's dumb, but it probably makes the point. Now, glucagon promotes the degradation of fat and the release of free fatty acids and the conversion of free fatty acids into ketone bodies. So let's use an example. Let's say Maddie over here had waffles for breakfast with syrup, okay? And those waffles are basically starch, and the syrup is largely glucose. So her insulin levels, in response to increased glucose levels in the blood, her insulin levels go up. Her glucose levels will go up, and now the insulin tells cells to take up glucose. So her glucose levels go up, and they come right back down. Her glucose levels will never get above 200 milligrams per deciliter, unless she really, really, really overdoes it. So in a diabetic, those levels would soar, and they get above 200 micrograms per deciliter. But in Maddie, who was young and fit and very athletic, it'll go up to maybe 140, 150, and then it'll come right back down. Then she goes to class. She does nursing stuff. She doesn't eat until about, 1 o'clock? 1 o'clock. Now she's in the post-absorptive stage. Remember, you hit the post-absorptive stage about after 2 hours. Glucose levels now start to fall. Glucagon is now made by her pancreas. Glucagon will now cause the release of that stored glucose. It'll cause the release of stored fat. It'll cause a release of that, and now her glucose levels will come back up until she can't eat again, which is usually around lunch, and then the same dance repeats itself. So these hormones are made in the endocrine portion of the pancreas. The pancreas is a little bit schizophrenic. It's a little bit exocrine, it's a little bit endocrine. Well, frankly, it's a lot of exocrine and a lot of endocrine. So the exocrine part consists of the ACE and R cells, those clusters. They make the enzymes and the bicarbonate. It gets secreted into a ductal system. That ductal system gets released into the duodenum. That's the exocrine system. Islands in between this exocrine system called pancreatic islets, also in some books known as the islets of Langerhans, they consist of cells that secrete their materials straight into the bloodstream. So they are endocrine cells. We take a little closer look at these cells. There's two populations of cells for today. You need to be aware of alpha cells. Alpha cells secrete glucagon. They secrete glucagon in response to low glucose levels. Glucagon made by alpha cells. Beta cells secrete insulin. They secrete insulin when glucose levels are high. Also, insulin and glucagon mutually inhibit each other. High insulin tends to inhibit glucagon production. High glucagon tends to inhibit insulin production. So here you have your cartoon of your pancreatic islet. Notice there are blood vessels close by. So whatever they make goes straight into the blood vessels. You have alpha cells. They make, hit me with it, glucagon. You have beta cells. They make insulin. Alpha cells make glucagon in response to low glucose. Beta cells make insulin in response to high glucose levels. Delta cells, we won't worry about those now. Now your normal fasting glucose will be between 65 to 100 milligrams per deciliter. This is one of those lab numbers you should just know. There are several lab numbers you should just know. This is one of them. Between 65 and 105 milligrams per deciliter. If someone is a non-diabetic, that's the range they will fall into typically with a fasting glucose. So again, Maddie eats her waffles, and with the syrup, of course, glucose goes up, beta cells release insulin, glucagon levels tank. We get increased cellular uptake and utilization of glucose. Glucose levels now go down. That will now inhibit insulin production. As she goes to class, as she does nursing stuff and what have you, now she's in the post-absorptive stage. Now glucose levels fall. Alpha cells make glucagon, insulin levels fall. High glucagon inhibits insulin. Now you have decreased cellular uptake of glucose, increased lysis of glycogen, increased gluconeogenesis, the production of glucose from small molecules in the liver. Glucose levels go up. That eventually feedback inhibits the release of glucagon. This is the star of our show, insulin. Insulin is made as a peptide like this, and it has the front and the back end of the protein locked together with these disulfide bonds. Then this piece here in the silver actually looks like blue. Well, it's silver here, but it's blue there. That piece is lopped off. It's cut out. That's called the C peptide. C, as in clam chowder. That C peptide gets thrown away. Now, for biologists, the C peptide is an excellent way to measure how much insulin cells are making. So it's antibodies to that are used in the lab all the time, because you can raise high affinity antibodies to the C peptide and they work beautifully. But for our purposes, this is insulin. You have the B peptide and the A peptide. The B peptide and the A peptide. And the B peptide and the A peptide, they're locked together. That's what's going to bind the insulin receptor. So insulin promotes storage of digestion products. inhibits breakdown of fat and protein, inhibits secretion of glucagon, stimulates glucose uptake because it puts this protein into the membrane that causes cells to take up lots of glucose. That's why insulin lowers serum glucose levels, because this protein is called GLUT4. GLUT4. It's a glutton for glucose. GLUT4. And when GLUT4 is put in the membrane, there's a glut of glucose. So it's a GLUT4 glucose. That's how you, well, how I remember it. You can use it too if that helps. This is especially the case in skeletal muscle, liver, and fat. Those are the three tissues that respond the most robustly to insulin: skeletal muscle, liver, and fat. You bind the insulin receptor, a signal gets sent to the cell, and all kinds of heck breaks loose. Essentially, two different pathways get activated. One of these pathways says survive, don't die, and grow. The other pathway says turn up your metabolism, bring in glucose, break it down, use it to make stuff. So one is build, the other is survive and grow. And so all these signaling pathways, they cause increased glucose transport, increased protein synthesis, increased fat synthesis. They will cause increased glycogen synthesis, glucose synthesis, well, it's glucose polymer synthesis, and also growth and gene expression as well. Now, if someone has untreated diabetes, they start to waste away. They get this condition you see sometimes in cancer patients called cachexia. If any of you work with cancer patients, you'll see cachexia. It's a terrible thing to watch. Untreated diabetics will get cachexia because they don't have the benefit of the major anabolic hormone in their body. So you put GLUT4 in the membrane, you take up lots of glucose, and all the signal transduction pathways lead essentially to these events right here. I don't want to go through the cell biology, that's for another class. Now, the oral glucose tolerance test is the gold standard test for diabetes diagnosis. In fact, in physiology, I think you did a lab where you drank high glucose solution and took your blood sugar test. Did you do that? No? You did the goldfish? I think it's much more interesting when you prick your own fingers and do that. Anyway, the goldfish goes turbo and yeah. Yeah. So with an oral glucose tolerance test, you fast for 12 hours, you come in, you get a baseline blood glucose level using a glucometer. You guys have used those before. Then you drink glucola. It's disgusting. It's 25% glucose. You drink 4 milliliters per kilogram body weight. Your glucose level now will climb, as will your insulin. 4 mils per kilogram body weight. You've never what? Is this for gestational diabetes? That's a different test. That's a different test. Pregnant women, they only fast 6 to 8 hours. And then you give them less glucose. Because you give them too much, they're going to upchuck because their stomach is more sensitive. Yeah, that protocol is different than for a non-pregnant individual. So what I gave you was for a non-pregnant. Gestational test is a kinder, gentler. oral glucose tolerance test. So you take their blood sugar every half hour on the half hour for about 2 hours, and you're looking for the blood glucose to go up, just like with Maddie on her waffle, and then to come down. In a diabetic, it'll go way up and it'll come down really sluggishly. So here you see insulin goes up, comes down. Blood sugar goes up a bit, then comes down. Diabetic, type 1 diabetic, there's no insulin peak, and the blood sugar goes way up and comes down very, very sluggishly, very slowly, if at all. That is an oral glucose tolerance test. If you peak above 200 mg per deciliter on an oral glucose tolerance test, that's an automatic diagnosis of diabetes mellitus. Any questions on insulin before we now beat the horse on glucagon? No? Okay. Glucagon stimulates breakdown of glycogen. Glycogenolysis is breakdown of glycogen. Stimulates gluconeogenesis, making of glucose from small molecules in the liver. Stimulates breakdown of fat. That's what lipolysis is. Stimulates ketogenesis, the synthesis of ketone bodies. The production of fatty acids allows these tissues to use fatty acids for energy. These tissues use fatty acids because they're sparing glucose for the brain. The brain has a relatively absolute requirement for glucose. The brain takes up glucose by facilitated diffusion, so it's concentration dependent. Remember what Amanda said happens to your behavior when your glucose level tanks? You get loopy, you get confused, you start saying things that don't make any sense. You lose your speech gets slurred. You can't talk, you lose consciousness eventually. When your glucose level gets too low, your brain can't take it up. That's why you need to maintain the glucose level between 65 and 105. So this shows essentially what glucagon does in a pictorial fashion. The targets are fat, fatty tissue, fat. Skeletal muscle is not a target for glucagon. The liver. So it's the liver, fatty tissue. These will make fatty acids. Those are converted into ketone bodies. Glycogen is degraded to glucose 6-phosphate, which is then dephosphorylated. That's released into the bloodstream. Early in the morning, you get a flush of glucocorticoids. Those glucocorticoids will cause skeletal muscle to degrade some of their protein to make amino acids. Those are then used to make sugar via gluconeogenesis. And some of that can also be used to make ketone bodies. Did your mom ever tell you breakfast was the most important meal of the day? That's why. Because of the surge of glucocorticoids you get in the morning. If you don't, you're actually going to lose skeletal muscle mass. See, your mom was right about something. The autonomic nervous system also influences the production of insulin or glucagon. The sympathetic nervous system stimulates the release of glucagon and inhibits insulin release. That gives you stress hyperglycemia. Stress hyperglycemia. So if Victoria is, let's say Victoria gets up and goes out for a run, and she in the morning, and she runs up and she encounters that house over on the left past King Road where they have that big dog. They'll come out and chase you. And then Victoria discovers that she could have been a sprinter in another life because she's trying to get away from that dog. Then she says, man, how did I run that fast? Stress hyperglycemia. She got this boost of glucose that fed her muscles for anaerobic production. Parasympathetic input stimulates insulin secretion. That shouldn't surprise you. Parasympathetic input has to do with the rest and digest response. So Sympathetic is fight or flight. Parasympathetic is rest and digest. So insulin is all about digestion, using the products of digestion. I'm going to come back to that. So this essentially illustrates what I was just saying. You absorb a meal, glucose goes up, insulin goes up, glucagon goes down. You form fat, protein, glycogen, glucose, amino acids, fatty acids, ketone bodies go down. You go for a while without eating, glucose levels drop, insulin's low, glucagon's high. Now you hydrolyze glycogen, fat, protein maybe a little bit later, and then you get gluconeogenesis, ketogenesis, glucose goes up, amino acids goes up, fatty acids goes up, and ketone bodies go up. Now, diabetes, there's two types, type 1, type 2. Type 1 is an autoimmune disease. The beta cells have been destroyed by the patient's own immune system. You can get diabetes because of trauma to the pancreas. Let's say you get a blow to the midsection because of a steering wheel. You now burst open those acinar cells, and all those enzymes are now activated. What are they going to digest? The pancreas. What's in the pancreas? Beta cells. That can cause you to become diabetic too. So can certain viral infections. They can cause you to become diabetic as well. By hook or by crook, your own body destroys your own beta cells. You don't have beta cells, you don't make insulin, you must inject yourself with insulin. That's type 1 diabetes. Type 2 diabetes. The insulin levels are fine, but insulin doesn't work anymore. The cells are resistant to it. The cells lack sensitivity to insulin. That's type 2 diabetes. So you will take medications that sensitize your tissues to insulin. Okay, is that part clear? Want me to say that again? Emily?
So are there still type 2 diabetics that take insulin
If the beta cells become exhausted, then yes.
though?
Also, if you start out with a type 2 diabetic whose blood sugar is really high, they need to take insulin because that's the only thing that's going to get it down. So some type 2s will actually start on insulin. You get the blood glucose level down because it's been high for so long that you're not going to be able to treat them with metformin and get it down. All of a sudden, they'll need to be on insulin, and then once they get it down, then you switch them to metformin, and yeah. That's why you may have a type 2 diabetic who comes in, their blood sugar is 500. And the endocrinologist will say, we need to get you on insulin. You need to get that down, then we'll transition you to metformin or something like that. The guy has a blood sugar of 500, diet and exercise are not going to get that down. They need medication. So, as Amanda said, the clear majority of diabetics are type 2s. Type 2 diabetes is associated with obesity and being overweight. Reason for that is that fat cells are endocrinologically active. They secrete hormones. They're called adipokines. Adipokines. When you don't have very many fat cells and they're not very big, you secrete adipokines that actually sensitize tissues to insulin. When you get more of them and they get bigger, then they start changing their adipokine profile, and you start making adipokines that cause cells to become less sensitive to insulin. That's why type 2 diabetes tends to be linked to obesity. And this essentially says everything I've already said. I'm just going to go on. So type 1 diabetes tends to occur in kids. Although there are cases of 38-year-olds will all of a sudden become diabetic after a viral infection. That happens too. Some RNA viruses, Coxsackie virus, certain enteroviruses, they have a tropism for the pancreas, and they can affect the pancreas and cause diabetes. You tend to get this lagging between fat synthesis and the rate of lipolysis. The kid gets very thin. Amanda told you about ravenous hunger. They also start having to drink volumes and volumes of liquid. 3 signs of diabetes, the 3 P's. Polyphagia, eating all the time. Polydipsia, thirsty, drinking all the time. Polyuria, peeing all the time. Those are the 3 P's of diabetes. Now, gang, I want you to hear me on this. Tom Kunzelman's wife, Melanie Kunzelman, when her son became diabetic, she missed it. Why did she miss it? She was too close. When you're too close, you lose your objectivity. Melanie knows this better than I can. She can rehearse this in her sleep, yet she missed it because it was her own kid. You have to not sacrifice your objectivity. Can you get close to your patients? Yes. When they die, you'll cry. Yes. But you must maintain your objectivity or you will miss things and you won't do your patients any good. Okay, that's my sermon for the evening. Yeah?
Okay, so at what point do you say, okay, they're having excessive, like what makes it excessive? Like,
Excessive what?
like thirst, or like how many times is too much eating in a day? And like what do you guys talk about? Like what's your calculating using some water a day? Like how do I know if that's excessive? How do I know?
Having to drink every half an hour, loads and loads and loads of liquid. Diabetics have a thirst that cannot be quenched. They'll drink a whole gallon jug of water and they're still thirsty. That's not normal. Can we agree that's not normal? Yeah, that's the kind of thirst of drinking that you'll see. And then having to run to the loo every 15 minutes or so because of all that drinking. And then Amanda talked about the breath being fruity. That's very, very common. The other thing you see is because glucagon levels now start to soar, you get extensive ketoacidosis because of ketone bodies. Those ketone bodies that are made, they're acetone, beta ketobutyrate, and acetoacetate. 2 of those are organic acids. They're going to lower the pH of the blood. That's going to, your body then to respond, you're going to start to have Kussmaul respirations. Puffing, trying to get rid of CO2 to try to get the pH back to normal. That's another sign of ketoacidosis, is the Kussmaul respirations, of the panting. So this essentially leads to a condition. You're getting rid of ketone bodies, you're getting rid of sugar, because gluconeogenesis, you have more glucose, that gets kicked out through the kidney. This is going to cause tremendous amounts of diuresis. You lose fluid, you lose electrolytes, you get tremendous dehydration and hypotension and electrolyte imbalances. Gang, this can lead to coma and death. This is nothing to mess with. This has to be treated. And Amanda told you how you treat this. Remember what she said? How do you treat this? Fluid. You flush this out of the system and you give them insulin so that the glucagon levels now come down and you stop this insane production of ketone bodies and glucose, and then this gets flushed out with fluid. Type 2 diabetes tends to be gradual in onset. You tend to see it in older patients. You're starting to see it more and more in younger patients now, as childhood obesity becomes a problem. Would somebody please tell me why they're canceling recess in school with child obesity problems? Whoever proposed that should have all the paperwork wadded up in a ball and have it thrown at them. Kids need to get out and take the mask off the kids when they're outside. Good gosh, CDC, what are you thinking? Sorry. Anyway, I'm good. So we can see essentially that the oral glucose tolerance test, you're going to get results that start to look worse and worse. Now at the pre-diabetic zone, that's reversible. Once it gets up here, it's not so reversible. You need medication. You can see the insulin levels at first will soar, and then as the beta cells get exhausted, now you get this severe type 2 diabetes. And Emily, to your point, now this type 2 diabetic will need insulin. They're not only insulin resistant, they're also insulin insufficient. Some people also have so-called reactive hypoglycemia. You may have known some people like this in your lifetime. They have a sugar-rich meal, and all of a sudden their blood glucose drops and they pass out or something like that, or they get really woozy or what have you. These individuals, essentially, when they get a lot of glucose, their pancreas essentially goes insulin, essentially, and their blood glucose level really drops. These people are predisposed to type 2 diabetes. So if you have that, you're going to have to be careful. So the bottom line is insulin causes cells to take up glucose. Without proper insulin signaling, your blood glucose level remains high, and hyperglycemia, which again, remember, fasting blood glucose, give me the numbers. 65 to 105. I want you to write that on a 3x5 card, tape it to your mirror. I want you to see it every day and rehearse that. Get that burned into your head. 65 to 105 milligrams per deciliter. If you're above that, if your fasting blood glucose is above 105, you're pre-diabetic. If it's above 120, you're definitely a diabetic. So that 105, 106 to 119, that's your pre-diabetic zone. Now, an old experiment was done years ago, and this led to the discovery of molecules in your body that are now being exploited for medicines for type 2 diabetics. I don't know what it is about this mask, but something goes up my nose and it itches like mad. So annoying. If you inject a mouse with glucose or give it intravenous glucose, here's the amount of insulin you get. If you feed them glucose, now you get an extra boost of insulin. There's something about glucose passing through the GI tract that beefs up your insulin response. Turns out there are cells in the duodenum and in the jejunum called L cells. These L cells, when they sniff glucose, they secrete these molecules that are called incretins. And incretins get secreted into the bloodstream. They're endocrine hormones. They go to the pancreas and they prime the insulin releasing pump. This is called physiologically a feed-forward mechanism. A feed-forward mechanism. It's kind of like when you're playing capture the flag. You're chasing that person you just can't catch. You're going for the flag, but you know your friend is near the flag, and you go, you say something, there's a code word you use, saying Indiana or something like that, and then your friend comes out hiding from near the flag and catches them. Do you guys play capture the flag? It's been a long time, okay. We used to do that here during freshman orientation. The core groups used to play capture the flag. They'd have a flag over here and a flag over there, and the teams would have to capture each other's flag. And okay, you're never a freshman. Yes, you were born a toddler. Yes, okay. Anyway, whatever. It's a feed-forward mechanism. Now, there's two peptides that are incretin. Glucose-dependent insulinotropic peptide. Good golly, that's a lot. Let's call it GIP, shall we? GIP. And then glucagon-like peptides, GLP. GIP, GLP-1. Those are your incretins. They prime the insulin pump. And they feed forward. They cause the pancreas to release more insulin. You get greater insulin bang for your glucose buck, essentially. Now, there are medicines that mimic incretins that are used to treat type 2 diabetics. We'll see how those work. Now, incretins, as it turns out, are degraded by a protease called dipeptidyl peptidase 4. That's a mouthful. Let's call it DPP4. Is that okay? If you inhibit DPP4, now the incretin half-life gets longer and you get more insulin bang for your glucose buck. And so there are drugs that inhibit DPP4, and they're used to treat type 2 diabetics. Then, of course, you have your insulin. We talked last time briefly about the different types of insulins. The biggies for us will be, first of all, rapid acting and the long acting. The other two, fast acting, that's normal insulin. These two are used mainly by type 2 diabetics now. They're trying very hard to put type 1 diabetics on pumps, just because the research has shown you get much better control with a pump. With pumps, it's all rapid acting insulin, all of it. Then there are medications that increase the amount of insulin your beta cells release. Those are your insulin secretagogues. There's two types. Sulfonylureas. Sulfonylureas tend to act over a long period of time. So you take them in the morning, they're good all day. Gliptinides, they're short acting, short half-life. You're going to eat, you take them, you get increased insulin, you eat, that deals with your meal. So they're good for short-term use. Then you have the biguinides, which includes metformin. Metformin is the mainstay treatment for type 2 diabetics, the mainstay treatment. And it sensitizes the liver to insulin, decreases glucagon production, and so on and so forth. Wonderful drug, very cheap, very effective, used a lot. Then there's the thiazolidinediones. Good gravy. Who names these things? Let's call these the TZDs. The TZDs. These cause your peripheral tissues to become more sensitive to insulin. That's how they work. The TZDs. Then you have the gliptins. These inhibit DPP4. These all have gliptin at the end of their name. Sitagliptin, saxagliptin, linagliptin, allogliptin, so on and so forth. Your mother-in-law gliptin. If you see gliptin at the end of a drug, that's the kind of drug it is. It's for type 2 diabetes. Then you have drugs that mimic incretins. These you inject. But one of them is now available as an oral medication. And these tend to end with glutide, liraglutide, dulaglutide, semaglutide. Okay, exenatide is the oddball. Exenatide was the first one. That goes by the trade name Byetta. Liraglutide is Victoza. These drugs spare the beta cells. When you take these drugs, your beta cells are spared. Your chances of your beta cells going south decrease. Then you have the SGLT2 inhibitors. We saw these with heart failure, didn't we? Now we're seeing them with diabetes. These work in the kidney. They prevent the reabsorption of glucose. So they increase Water and sodium loss as well. They lower blood pressure. They lower blood volume. They decrease pressure on the heart. They also tend to be good for the kidney. Notice these end in glyphlosin, glyphlosin, canagliflozin, empagliflozin, dapagliflozin, ertugliflozin, your sister-in-law gliflozin. You see gliflozin? It is one of these. They work in the kidney. So with these, you have to worry about dehydration. And you have to worry about increased urination. And in women, you have to worry about urinary tract infections and stuff like that. All right. Those are the agents. That's how they work. The next set of slides is how you use them. Let's take our break. Let's come back after 5 minutes. Let's talk about how you use them. Have I lost you guys for the rest of the evening? Have I lost you guys for the rest of the evening? You just, oh, guys, I forgot. My wife made you guys oatmeal raisin cookies. And by the way, she's very much for her part.
Yeah, where they're actually live. Oh, it's probably about Peter Bennett. Rational. I've also been concerned with and no, they're like, it's here.
Oh, this is porch fat.
Yeah.
That's what that is, it's porch fat. Okay.
Anyone know the long person? No. I feel like there's kind of stuff at the first time, like, nothing like this, so we can like, we'll plan this on a Wednesday night. Exactly. Or like, there's like a thing in the nurse building project. Yeah, exactly, yeah. All the time.
Makes me sad, like, I wish I had a life, but I don't.
Seriously. It's not like I'm saying like you're watching like
You may not have a life now, but you will have a career that will be very satisfying, that will remunerate you well. You will touch a lot of lives. So, is this hard? Yes, it's hard. Anything that's worth doing is hard.
I have a question on that.
Yeah.
So on this, so given the treatment algorithm, we're gonna refer to this.
Yeah.
So for like moderate asthma, would you say step 2 or step 3? Or would you try step 2 and then like,
Moderate persistent.
yeah,
Moderate persistent would be this.
would be step 3?
Yeah, would be 3.
Okay.
Yeah.
Thank you.
And moderate can there's kind of severe moderate and light moderate. So severe moderate
I figured
can actually go up to, it'll kind of straddle.
Okay, so I figured he'd probably be almost severe moderate.
Yeah,
He's like on the verge, but not
he's really on the border. And the thing is, you try not to over-treat.
Yeah,
You usually try the
bare minimum.
well, the minimum that you know will work. Then if that doesn't work, then you bump it up.
Thank you.
Okay, folks, let's resume. Feel free to eat as many cookies as you want. All right. Okay. Type 2 diabetes sometimes can go undiagnosed for a very long time. Sometimes the first people to catch it will be the dentist, because type 2 diabetics often will get wounds in their gums and they heal very, 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 very slowly. And so the dentist very often will be one of the first people to suggest that there might be a problem with type 2 diabetes. So type 2 diabetics, their skin will be dry and itchy, and they will have slow healing of cuts or sores. That's one of the first signs. And if it gets really bad, then their vision will start to become blurred. They'll get numbness and tingling in the hands and feet, frequent infections. In elderly patients, it might actually be asymptomatic. And it may be difficult actually to diagnose sometimes. So we talked about the pathophysiology, we talked about the signs. The big thing with diabetes, the complications long-term are quite severe. You have diabetic vascularitis. Since your vascular tree or microvasculature feeds every organ and tissue in your body, this can affect any organ or tissue in your body. You have diabetic nephropathy, diabetic cardiopathy, diabetic neuropathy, and diabetic retinopathy. These can be prevented through tight control of the blood sugar, but it takes discipline. It takes information and education, and that's where you all come in. So, fasting blood glucose level of over 126 mg per deciliter, or symptoms of diabetes plus casual blood glucose concentration of up to over or equal to 200 mg per deciliter, or a reading of 200 over or equal to 200 mg per deciliter in a oral glucose tolerance test. Any of those merit a diagnosis of diabetes mellitus. So normal fasting glucose is 100 usually. Impaired is equal or up to 100. And a diagnosis of diabetes would be fasting glucose of 126 mg per deciliter. Who should be screened for diabetes? Anybody 45 or older, or anybody under 45 years is obese, has a first degree relative, or diabetes mellitus, high-risk ethnic groups. That would include Latin Americans, African Americans, history of gestational diabetes, or if they delivered a baby greater than 9 pounds, or if they have a history of hypertension. So your goals are pre-prandial glucose, 80 to 100 mg per deciliter, bedtime glucose, 100 to 40 mg per deciliter. You want to try to get the A1C. Do you guys know what A1C is? So glucose is a very reactive molecule, and one of the molecules it reacts with is hemoglobin. So when you draw blood, you do a CBC, you can do a very quick test for glycated hemoglobin. Hemoglobin that's reacted with glucose. That is a gauge for how much damage glucose is doing around the body. So it's a gauge for how well your patient has been controlling their blood glucose. Amanda said they're starting to move away from that. It'll take a while before they completely move away with that from that, but your target is below 7. With kids, you're trying to get them at 6.5, but it's usually 7 or below. We went through this again. I can't emphasize enough the need for diet and exercise in both groups. Exercise is a known sensitizer of tissues to insulin. Even light exercise, even walking, can be a prominent sensitizer of tissues to glucose. That's why in the UK, very often physicians will prescribe for obese patients, get a dog. They'll actually write a script, get a dog. And you take that to the RSPCA and you get a dog. Because what do you have to do to a dog? You have to walk it. And so the British love their dogs, and there's an old bromide about, yep, he's a Yorkshire chap, he loves his dog and his walk, and that will actually force you to go for a walk every day. How do you get a dog around here? Humane Society. If you, you can have an emotional support animal, but you have to have a documented emotional issue to do that. Otherwise, find someone with a dog and borrow their dog. The Cottinghams just live over there. They have a dog. You can borrow their dog. Nutrition. You're in nutrition now. You have to be able to have adequate carbs to match the peak action of insulin. You have to count carbs. Now, counting carbs at first is very difficult, but diabetics, and Amanda can do this. We were together once, and I was just, okay, Amanda, how many grams of carbs? She, 20, 25, 35, 50. And she was just able to do that because she'd done it so much in her head. And it's a guesstimate sort of thing. But they have to essentially be able to do that. You have to regularly schedule your meals. Diabetics are often tempted to skip meals. They shouldn't do that. They shouldn't do that. And you're trying to prevent the big swings in blood glucose level concentrations. For kids, you want to maintain normal growth and development. Not just development, but also sexual development. That's important too. Did you guys talk about the Tanner stages in A&P? When you do PEDS, you will. You want to have proper Tanner stage advancement through the Tanner stages. I think I just lost all of you, but just write down Tanner stages. For type 2s, you want to achieve and maintain optimal glucose, lipids, and blood pressure. Achieve and maintain a weight loss goals. That's hard because some of the medicines we'll see actually promote weight gain. That's going to be hard. So a disciplined diet and exercise regimen will be really important. Increase your physical activity. Again, gradually watch the types of foods you consume and the quantity. The quantity. Very often people, research has shown, vastly underestimate the quantity of something they eat. So let's talk about type 2 meds first. First, you have those classes that will improve insulin secretion. The big guns here are the sulfonylureas. Then you have insulin sensitizers, biguinides and TZDs. Then you have those that decrease the absorption of glucose, the alpha glucosidase inhibitors, and then the dipeptidyl, the DPP4 inhibitors. Those improve insulin production, and then also the incretin mimics as well. Let's talk sulfonylureas. These are the sulfonylureas, but I'm going to make this really easy because most of these have been pulled from the market. There's 3 that are available on the market now, the ones in bold. Gliptins, biguanidine, which is usually called glyburide, and then glimepiride. Those are the 3 of these that are available. If you use sulfonylureas, you almost always combine them with metformin. You almost never use them as a monotherapy. Sulfonylureas, they promote weight gain because they cause you to make more insulin. Insulin causes fat deposition, so they promote weight gain. They can cause some GI distress that tends to go away, but it can be severe in some people. They can also make you sensitive to sunburns. They cause rashes in some people. Stevens-Johnson syndrome has been reported, but it's not at all common. It's rare. The biggie is that they can cause hypoglycemia. So be able to identify the signs of hypoglycemia. This is important. So with mild hypoglycemia, you get tachycardia, you get hunger, you get shakiness, irritability, and usually pallor. That can be fixed with usually a half a cup of fruit juice, glucose tablets, a box of raisins, a cup of soda, or a cup of milk. Easy fix. So mild is your blood sugar gets below 60 mg per deciliter. When you're below 60, you're hypoglycemic. Now moderate, now you're below 40. Now you have an inability to concentrate. You have confusion, slurred speech. The behavior is just irrational. Reaction time is slowed. Vision is blurred. Extreme fatigue. If you're at home, you can fix this with a tall glass of juice, but wait 30 minutes before resuming activity. If it gets really bad, you'll need IV glucose. Severe, you're below 20, provided you're still conscious. Disoriented behavior, loss of consciousness and inability to arouse from sleep. Seizures, coma, and if it's not treated, death. The risk of hypoglycemia is higher in the elderly. Now, the elderly, they get disoriented, they're at greater risk for falls. Also, if they're on a beta blocker, the beta blocker will mask the tachycardia. Another thing to consider. So take the drug as prescribed. Know the name of the drug, know the dosage, make sure the patient, knows the name of the drug and the dosage too. Inform the patient of side effects. Doctors' offices, hospitals usually have sheets that you can give to diabetics that will list all these things. Emphasize the pills are not insulin. They're not a substitute for diet for exercise, and they are not a cure for insulin. You must keep taking the pills as directed. So, for you, the nurse, sometimes hypoglycemia comes on like a shot. If it comes on like a shot, then the patient will experience sympathetic nervous system type symptoms: tachycardia, palpitations, diaphoresis, shakiness. If it comes on gradually, they'll experience parasympathetic symptoms: headache, tremors, weakness. So educate the patient to self-administer a snack that consists of 15 grams of carbohydrate. And here's the 15 grams: 4 ounces of orange juice, 2 ounces of grape juice, 8 ounces of milk, glucose tablets as directed. If the symptoms get really bad, call your doctor. If the hypoglycemia is severe, then IV glucose might be required. Weight gain. Encourage the patient to adhere to a diet and exercise regimen. Diabetes is not a death sentence, but it must be managed. Any questions about sulfonylureas? Biguinides, the one drug is metformin. There's another biguinide, but it was pulled years ago because it caused severe liver damage. This is the one that goes by the trade name glucophage. It does not stimulate insulin secretion, but it decreases hepatic glucose production. It increases glucose utilization by muscle. You take it with the first bite of food. This drug allows you to lose weight. Many people lose weight. In fact, metformin is used off-label as a weight loss prescription. GI issues are usually the biggest issues, but with the XR, the long-term release, the GI issues are much less frequent. Metformin does not produce hypoglycemia. That's one of the great advantages of it. It does rarely produce a condition called lactic acidosis. This is rare. When it occurs, though, it's very severe. You get unusual muscle pain, labored breathing, stomach pain, irregular heartbeat, weakness, dizziness, tremendous fatigue, and you get, strangely, a metallic taste in your mouth. Now, two things about metformin. You don't give metformin if people have liver disease. You don't give metformin if people have renal disease. They're not going to win any awards for singing, that's for bloody well sure. So with the GI effects, you may get substantial weight loss because of the loss of appetite and just the nausea, the diarrhea. But these subside with use consistently. So reassure the patient they will subside with use, but monitor for the severity of these effects. You might need to discontinue the medication if necessary. That's usually not the case. Sometimes you can back down the dose and things will improve. So those are things to consider. The other issue is you're going to have altered absorption. So you get vitamin B12 and folate deficiencies. Now, one of the ways you can fix this is to use sublingual supplements. B12 comes in a sublingual supplement, so does folate. In fact, Celebrate Vitamins makes a quick melt B12 with folate tablet you put under your tongue. It's even flavored. Comes in orange and grape. And you get B12 that way. You don't have to swallow anything. So that is a potential fix to the B12 deficiency. But remember, B12 deficiencies, what do they cause? Not pernicious anemia, well, they could B12 can, but with folate, it'll cause megaloblastic anemia. Then lactic acidosis. Symptoms, we went over those, remember? This has a 50% mortality rate. If it comes up, you withhold the medication and inform the physician immediately. You treat this with hemodialysis, but you have to do this ASAP. ASAP. No messing around. Acarbose and miglatol. These inhibit brush border glucosidases that degrade complex carbohydrates. So you delay absorption of glucose. So your glucose doesn't do this, it does more this. These drugs are never used as a monotherapy. They're always combined with other drugs. So they reduce the postprandial surge. They have a modest effect on lowering fasting glucose, but they can be a genuine lifesaver for some patients. Big issue with these drugs is that they cause abdominal cramping because the bacteria in the GI tract now start to ferment those complex carbs. They generate a lot of gas, a lot of organic acids. That's what causes the cramping, hyperactive bowel sounds, excessive gas. So essentially watch this. If it gets really bad and it's really embarrassing, discontinue the medication. There is an over-the-counter medication you can use for gas, simethicone, which I think the trade name is Gasex. Simethicone is well tolerated and it will help with the gas. You decrease iron absorption. So you can get some anemia on this drug. So monitor hemoglobin and iron levels. If this gets really bad, discontinue the medication. The other issue is hepatotoxicity. So get a baseline LFT, perform LFTs on a regular basis. When you get off the med, usually the liver function returns to normal. Just discontinue it if necessary, otherwise, give it some time. So don't give if the patient's hypersensitive to it. Don't give in cases of cirrhosis or diabetic ketoacidosis. Don't give if there's inflammatory bowel disease. Don't give if you have chronic intestinal diseases of some sort. Don't give in examples of renal insufficiency. Those are all contraindications. I feel like I'm going through these really fast. You guys have time to write, or are you holding on for dear life? Okay, yeah, all right. TZDs. Big thing about TZDs, they cause increased fluid retention. That puts stress on the heart. So you can get heart issues while you're on TZDs. Also, TZDs cause you to gain weight because they increase insulin sensitivity of adipose tissue. So you gain weight on TZDs. You also get elevations. Your professor needs to learn how to spell elevations of LDL. And there are cases, there's a black box warning on this drug for hepatotoxicity. So for your TZDs, monitor for edema, weight gain, and indications of heart failure. Yeah, right. Heart failure. Get rid of the white. Monitor cholesterol levels. Put a star by that one. That's really important because with the increased edema, you might have increased atherosclerosis. So again, baseline and periodic LFTs. And then you have the patient report any signs of liver disease, jaundice, any sort of icterus, dark urine, Murphy sign, something like that. And now for the DPP4 inhibitors. So the incretin mimics will increase incretin. The incretin mimics are not subject to degradation by DPP4. The DPP4 inhibitors, they will work with your incretins and increase the half-life of those incretins. So these are the drugs. The granddaddy of this drug, the oldest one, is Januvia, sitagliptin. And then you have linagliptin, saxagliptin, malagliptin, Onglyza, Nizina, Tradjenta, Januvia, what have you. These drugs on the average are quite well tolerated. The sorts of things you see, as you can see, are very low percentage. Upset stomachs, just very basic sort of things. When you compare these to placebo, placebo is a little bit lower than these. So by and large, they're pretty well tolerated. Incretins. These are injected. They're injected sub-Q. They come in injector pens, and you inject them. So these two have short half-lives. So exenatide, you're going to inject 30 to 60 minutes before the first meal, 30, 60 minutes before the last meal of the day. So that's given twice a day. There's now an extended form of exenatide you only give once a day. Liraglutide, you give once a day regardless of when you eat. Then you have drugs that are very long-lived. These drugs you give once a week. One injection once a week. Pretty convenient, huh? So dulaglutide, abiglutide, semaglutide. This one you give once a month. And now there's a preparation of semaglutide called Rybelsus. It's actually oral. You take this as a tablet once a day. So the biggies with this is GI issues. Now these prevent the stomach from emptying. Food stays in your stomach for a longer time. You feel full for a longer time. You have increased satiety. So on these drugs, you lose weight. In fact, you can lose a lot of weight on these drugs. And in fact, liraglutide is now FDA approved as a weight loss treatment. The other issue with these drugs, and by the way, the GI issues, they tend to go away. They're not long-term. The other issue is pancreatitis. And when this happens, it's painful. Doesn't happen very often. 1.6 to 0.7 cases per 1,000. I wouldn't call that very often, would you? No, but can it happen? Will you see probably 1,000 diabetic patients in your career? You'll probably see more than that. So if it happens, you notify the doctor if the symptoms are intolerable. Pregnancy class C, so using pregnant women, no. Contraindicated, people with kidney failure, an IBD, ulcerative colitis or Crohn's disease, and a history of pancreatitis. Used with caution in people with renal impairment or with thyroid disease. There's reports of an increased risk of thyroid disease. A large study in the United States and UK showed that the rates of thyroid cancer in a test case of over 30,000 people weren't any higher than people who weren't taking the drug. So that initial report looks like it was bogus, but you see tissue changes in patients on these drugs. So don't give it to people with thyroid disease. Oral medications will show delayed absorption because of that decreased emptying. And if you use it with sulfonylureas, you increase the risk of hypoglycemia. SGLT2 inhibitors. Canagliflozin, dapagliflozin, epagliflozin, or tugliflozin. These can increase the risks of UTIs, particularly in women, not so much in men. Let me just read you from the this is from the medical letter. Population-based cohort study, 25,000 patients. SGLT2 inhibitors were associated with lower cases of all-cause mortality, lower rates of hospitalization, and lower rates of major adverse cardiovascular events. Meta-analysis of 3 cardiovascular outcome trials for empagliflozin, dapagliflozin, canagliflozin in 35,000 patients with type 2 diabetes showed that these lowered the risk of major adverse cardiovascular events, lowered the risk of stroke, heart attack, and other cardiovascular events, and they lowered the progression of renal disease by 45%. So these drugs have really proven their mettle in the last few years. Big issue with these drugs is the risk of dehydration and the risk of electrolyte imbalances. So make sure your patient drinks and drinks copiously. Also, these can drop some people, these will drop the glucose level like a rock. So watch for hypoglycemia when they first start taking it, particularly if they're combining this with another drug. Allergies to these drugs have been described. They're not common, but they do happen. Watch out for them. Insulin. We covered some of this yesterday. I won't read you the riot act on these. So insulin used to come from cows and pigs. Then with genetic engineering and Stanley Cohen and Herbert Boyer cloning the insulin gene, and then Boyer and Frisk starting Genentech Corporation. Now all our insulin is genetically engineered. The big risk with insulin is hypoglycemia. So be able to identify the signs of hypoglycemia, be able to educate patients in how to treat themselves if they have mild hypoglycemia with the 15 grams of glucose thing like we talked about before. So the rapid acting, we talked about those last time. These, you have very fast peak, very short duration, fast onset. They have Ephedra, Aspart, and Lispro. Then you have variations on a theme, so Fiasp and stuff like that. Those are all just variations on a theme. These are used in pumps. You have regular insulin, not used much anymore, but still available. Onset's 30 minutes, peaks 2.5 to 5 hours, duration 4 to 24 hours. Then the intermediate insulin. The big one here is NPH. That's the one that's used the most. So the intermediate insulins peak 4 to 12 hours. They can last up to 24 hours, but they last usually about 12 hours. These sometimes are mixed. Patients should never mix their own insulins. Let me say that again. Patients should never mix their own insulin. Now, will you be called upon to mix insulins for them? Yes, you will. And you'll be trained to do that in some of your courses. But patients should never mix their own insulins. Then you have the peakless insulins. So you have the Lantus. Notice Lantus, see, it's peakless. Same thing with Basaglar, Lantus, so on and so forth. Again, this one's crystals. Those crystals dissolve over a very gradual period of time. Then you have other long-acting insulins, the glutic and so on and so forth. These, if they're taken at all, you give yourself a shot usually in the morning, or with older type 2 diabetics, they'll give themselves a shot at night so that their blood glucose essentially will be stable during the night. Dawn phenomenon, this is really the case in kids. The dawn phenomenon is due to the fact that when you sleep, you release growth hormone. What does growth hormone do to glucose? Raises it. Because growth hormone tells cells to not take up glucose. Tells cells to take up protein, amino acids to make protein. So you can get hyperglycemia early in the morning because of this release of growth hormone during the night. That's called the dawn phenomenon. You treat it by increasing insulin dose at bedtime. Then in other people, you have so-called Somogyi effect, where you get rebound hyperglycemia in response to nocturnal hypoglycemia. Your glucagon then gets released. Then you get this rebound hyperglycemia. So decrease your nighttime dose of NPH. Give it at bedtime instead of dinner. Bob's your uncle, there you are. And we talked about patient teaching. Storage, Amanda told you about that. Rotate your injections. Again, tight control gives you reduction of complications. Pumps, you know about pumps. Dexcom, oral glucose, yeah, blah, blah, blah. Glucagon, she talked about that. Yada, yada, yada. There you are. Okay. Questions, anybody? Okay. I did the muscle relaxant one today. That's online as well. I'll send you the link as well to remind you of it. I'll do some more this weekend. Have a great weekend. Have a cookie for the road. And I'll see you guys next week.